Good afternoon, everybody. Dr. David Johnson here from the Back Pain and Functional Movement Training Centre and, of course, City to Coast Neurosurgery. This little video is about radiofrequency neurotomy, or otherwise known as radiofrequency ablation. Now, why am I talking about RFN or RFA? It's a very common procedure, and a lot of my patients have had radiofrequency procedures done for their back pain or neck pain, and I thought it would be valuable to people listening to just understand what in fact RFN is and why it's offered by parts of the back pain therapeutic industry. Who does radiofrequency ablation? Well, it's not commonly done by surgeons, but it's very commonly done by pain physicians, and radiologists will do the procedure, but radiologists will only do the procedure when the procedure is requested by another specialist or doctor. It's really only the pain specialists that will recommend having the procedure done independent of other doctors. Now, do I order RFN or RFA very often? No. The short answer is no. I can't remember the last time I ordered an RFN. Why is that the case? And can patients obtain some benefit from RFN? Well, if we think about this scientifically, what is the RFN procedure doing? Well, what it is actually doing is it is ablating or deactivating a nerve which is the sensory supply for the lumbar facet joint, specifically when we're talking about low back pain or lumbar facet joints. The medial branch nerve is what transmits pain signals from the lumbar facet joint to the spinal cord, and then that ascends to the brain for the perception of sensation from that facet joint. Okay, so it's like the messenger of pain. It's like the messenger of nociception or pain sensation from that facet joint, predominantly nociception or inflammation. So what are other functions of this medial branch nerve? Because if we're burning this medial branch nerve, what else does it do? Because if its only function is to transmit pain signals, then it might make sense to burn that nerve or defunction that nerve so that it can't transmit those pain signals. Well, it does also have another function, and that's not insignificant. The medial branch nerve also supplies neural innervation into stabilizing muscles of the lumbar spine, and that muscle group is called the multifidus muscle group, and that is an important that the multifidus has an important function in terms of controlling the way that each motion segment moves in relation to each other. So the way that the spinal vertebrae move harmoniously to affect movement proficiency. So and of course there are other muscles as well that contribute to this, not just the multifidus, the whole muscle bellies of the erector spinae, the psoas muscles and the abdominal muscles. All of those muscles are what we refer to when grouped together as our core muscles, because they control the stability of the spine. The multifidus have very short muscle bellies that really span one or one motion segment. So they link from one vertebral body to the other, as you can see there from the diagram. And when we burn the medial branch nerve, we not only knock off the sensory supply to the facet joint, but we also knock off the neural innervation to the multifidus muscle. And so that's not necessarily a good thing if we are trying to restore movement proficiency and eliminate movement dysfunction as a management therapy for back pain, which is primarily driven by movement dysfunction. And if we look at research that investigates how effective radiofrequency neurotomy is, then we're really left scratching our heads as to why the procedure is done so commonly, because the research doesn't really show significant benefit at all. And in fact, if you look at high-level studies which are randomized controlled trials, so a randomized controlled trial would be set up like this. You have half of the patients having the procedure, and then half of the patients not having the procedure. And the way that they randomize it is to do what's called a sham procedure. So the patient doesn't know whether they've actually had the procedure or not. And then you collect the data on outcomes of those patients. And remember, they don't know whether they had the RFN or whether they didn't have the RFN through a sham procedure. The actual outcomes are no different. And so it really doesn't stand well in the face of scientific rigor as an effective procedure. And that may be tolerable to some people if they feel that it gives them benefit, but in the absence of really good scientific data to say this is valuable, you then have to start weighing up the potential side effects of having the procedure. And there are side effects. I've talked about the loss of multifidus muscle stability, and also other potential side effects are dysesthesia and altered sensation, uncomfortable altered sensation across the back. So that's really the reason why I don't order this procedure very often anymore, because when I weigh up the risks and benefits of the procedure, it really doesn't hold up to scientific rigor. And it was interesting seeing this article that was considered one of the best spine articles of 2017, where NASA was investigating their astronauts, and they were correlating time on the International Space Station and loss of cross-sectional area of the multifidus group. And we used to think that their back pain may be related to that zero gravity environment and changes in relation to the architecture of the lumbar discs, but the more you look into it and correlate changes, loss of cross-sectional area of multifidus muscle seems to have a more significant role in the development of back pain in astronauts who are predisposed to back pain than changes to the lumbar disc. So it just adds further support to the importance of multifidus. And we have these muscles around our spine for a reason. It doesn't make any sense to burn the neural supply to these muscles unless there is some substantial value in doing it. And when you do randomized control trials, there isn't good evidence to support the RFN being that good anyway. So the final thing I want to show is a case example of this, whereby a patient had back pain. They had a nuclear bone scan. You can see that there, the hot spot or the tracer uptake in the facet joint. They then proceeded to radiofrequency neurotomy, and this did not help their back pain symptoms at all. And then this is the most recent MRI scan some months after the procedure, and it's very clear the big gaping hole in the musculature on the right hand side where multifidus normally lives, but right now there is there is significant atrophy of this muscle group. So hopefully that paints a fairly clear picture to you of the value or lack of value of radiofrequency neurotomy for chronic spine pain, and in particular chronic back pain management. So thanks very much for listening, and talk again soon.